Very good evening. I'm Dr. Chakravarti. So for those who joined here, just if you can put it on the Q&A box. So I guess all are preparing for the theory exams. And this session here has been designed so that for the next 45 minutes to 1 hour, it's just a quick revision of what are the main ways or what to sort of say, what are the main insights to make your time more productive, to make sure that your MRCPCH theory exams, you can do it in the best way possible, making use of your time in the wisest way possible. The problem we have here is that obviously most of us are like in very busy jobs, same as you. I was doing the same, and very stressful. Sometimes it can be very stressful on calls. You hardly get any time to rest, and so very little time to actually study. Obviously, then you've got to meet family, you've got friends, you've got a bit of social life. So in that circumstances, to go for the theory exams, specifically the FOP and TAS exams, can be quite challenging. I hope you can hear me well, Deepa, and I think the others. Just let me know. As I said, I'm sorry, the
Yeah,
chat,
sir,
you
we
can
can
hear.
hear you.
All right.
Yeah.
So I think, Deepa, see if we can use the, I don't know, the chat box for some reason it's not working, but if we can use the, uh, what do you call, the Q&A box, that would be good. If you can just check that, that would be great. Then we can at least communicate with the candidates. All right. So anyway, so that is the main purpose. Now, personally, before I start, so Deepa is, I think she's using the chat box. That's all right. Personally, I would like to start with telling that I personally struggled a lot with the theory exams. I was in UK at that time. We didn't have the exams in India at that time. The theory exams, we had to go to UK to give it, and it was a big struggle for me. It was a big struggle for me. I was in the new country. It was struggling to get a job, and even the job was difficult. And on top of it, the questions were obviously UK type. I was not prepared for it really. And that was when I thought about how we can make a course where your time, with a limited time, we have done a lot of work. Dr. Deepa here, Dr. Urmila, some of the other doctors have done tremendous amount of work to make it as simplified as possible. And we have gone through a lot of stuff, a lot of materials over the last at least 10 years or so. And obviously, Dr. Deepa has joined last few years as well to make sure that the material you study for the exam is relevant, is appropriate for the UK exams. Some of the problems we get here is that doctors in the India have no idea, not a very clear idea of what topics are there in the UK exam, and they miss it. So there are topics like ethics, like statistics, things like that, and also topics like like infectious diseases is not as important as in here. So obviously, you would again in medical conditions, there are conditions like cystic fibrosis which are more common there. I think those of you who are already doing the course know that, but many of us who are starting first are not aware of it. Anyway, so without wasting much time, I will go share the screen and just let me know if the screen is doing okay. Where I've just prepared a few slides, and obviously I've promised that it's a mind map thing as well. And we'll do a few questions through mind map as well, just to make it a bit more interesting, just a change from the slides. So with that, I'll just start by sharing a few slides about the nature of the exam. You know that, but just a few insights, which I think will help you. So if you can see it, just let me know, or some sort of message would be great. Are you able to see the screen? Okay, great. So, Khalid, thanks a lot, Dr. Khalid, for your interaction. Let's make it. I know this is a very precious time that you have come here, after a long day at work, and I appreciate whatever, the whatever input you're giving. So yes, if you put your hand up, if you make a question, that would really help. All right. That would really help. So first of all, to get an idea, we have put it here. As you can see, just let me get sort this out. Yeah, if you can see well and good. So now the thing about the MRCPCH is it's something called single best answer question. Now the MRCPCH theory is about single best answer. Now this itself you have to know, so it's not just about the knowledge you have in your, you might have a lot of Indian students are, very good. They have done their MD or their DCH and they have studied to Nelson and some big books. But for this exam, unless you're used to the particular type of question, which is the single best answer question, you will struggle. So let us talk about how to understand this. What are the things which have happened recently? So let me just focus on this one. What is single best answer for? So in September 2024, there was an upgradation. There were some changes made to the format of the exam. So what are the changes exactly? So now basically by definition, multiple choice question with exactly one answer out of the 5 options. As you know, the exams for it's got 2 parts where the clinical, where the theory, obviously the final part is the clinical, but before that, you have the FOP and TAS exam. Usually during our time, we could give the foundation of practice in the morning and the theory and science in the afternoon. So for that now, you have got 100 single best answer questions. So in the morning, 100 questions, in the afternoon, 100 questions for theory and science. 120 minutes is 2 hours. So not much time, only 72 seconds per question. 72 seconds per question. And why is this important? Because many of us candidates, who are doing okay, so-called okay, while they are practicing or doing the course or studying by themselves, who know a lot. But in that exam scenario, we are only have got only 72 seconds per question. That is where they struggle. That is where so many people get it wrong. The questions are designed in such a way that you will find that maybe out of 1 or 2, 5 choices, there will be 1 or 2 choices which are so close to each other. Unless you're very sharp, unless you're really prepared well, you can misread the question or you get so confused in the last 2 choices, you lose marks. AKP, so this is 2 parts, morning and evening. So that is part 2, we used to call it part 2 MRCPCH theory before we appear for the clinicals. And that had 120 single best answer questions, 300 minutes total, and 150 minutes per part. So there are 2 parts really, morning and afternoon. Now, if you see the question distribution, it covers all areas of pediatric medicine with emphasis on common conditions. So it's more like a GP, especially for FOP and TAS. It's like a general practitioner who's practicing in general practice, giving vaccination, dealing with common children illnesses. Those sort of questions would come. For you think of it obviously in the UK setting. So I'm just giving a simple question, just an example. So 14-year-old girl requests emergency contraception after unprotected intercourse. She refuses parental involvement. What is the most appropriate action? So this is the type of question. Now, for us being if the UK, the Indian, the candidates, this is a bit of a challenge because we are not used to adolescent medicine. You have to remember that in the UK, we used to have something called adolescent ward, where basically you have patients who are up to 18 years old. So they're almost mini adults. And there are the most challenging situations. As pediatricians in India, we are mostly used to seeing children up to 12 years, 13 years, or a lot of babies. And we seldom would in India would deal with this sort of thing, where you have to give advice about, emergency contraception, things like that, which is for which we have to be, if you're an Indian candidate, you have to be well prepared for these because you have to know the laws in the UK. You have to know, and there are a lot of medical legal implications for what you do. So I'm coming to that, but briefly, single best answer question structure. You have a clinical scenario or a vignette, then you have a question stem, and then you got 5 options, and you obviously give the best answer. So all are best of 5 format, and FOP and TAS previously 150 minutes, now they're 120 minutes only, 1 mark for all questions. And you have to remember that there is no negative marking. So you need to answer all questions. Just never forget that. Even if you don't know, make a guess, give it. Go for the best guess. There is no negative answers, no negative marking in these questions. Now, what are the key features of the single best answer? Why do you have to understand this format well? It's not recall, but also clinical reasoning and also based on real world pediatric scenarios. So it is not here, unlike, unfortunately, compared to a lot of Indian exams, they are not checking your, whether you know how many rare causes or rare scenarios or rare investigations. No, it's more about common things which are relevant to day-to-day practice, but obviously you have to know in a bit of depth. So that's why it can be a bit challenging. You have to know your stuff. You cannot just be casual about it. You have to know pretty good. So that is one thing. Now, varying difficulty. So the questions will vary. You be prepared that there will be some straightforward questions and there will be a few very complex questions, and that will decide your passing point. And obviously, discriminators, there are options designed to test common misconceptions. So they will give some options which are, which will test whether you are clear about those misconceptions. Now, as I said again, I'm just going through it again. With effect September 2024, there were changes. As I said, the duration has changed. FOP and TAS, as we talked about, the timing has gone. FOP and TAS from 150 minutes it went down to 120 minutes. The AKP timing has remained the same. Detailed comparison, like I think this was the previous format, and now the new formats from September 24. I think let's talk about the new format. You have to know foundation of practice, as I said, is mainly core knowledge. So core medical knowledge, you have to know a bit of physiology, bit of anatomy, bit of pharmacology, bit of microbiology, which are relevant to day-to-day pediatrics. So it won't be far, so don't worry, it's not something which is very rare, but obviously you have to study a bit, especially if you have done your pediatrics, your MBBS a few years and you're into practice and you're out of touch from MBBS days. Then because you will, I remember one exam where a candidate came to me, like he was already practicing for 5-6 years now. So obviously pharmacology was not in his, not top of his mind, the theoretical part. So at that point, there were a lot of questions based on pharmacology. So pharmacology means they were asking questions like mechanism of action, and there were a lot of questions asked in oncology. So that created a lot of problems. Or there will be a lot of questions based on mechanism of action of different types of antibiotics. So these are things you need to be aware about. Some questions on embryology related to the heart, cardiology, some physiology questions which are based on lung function tests. So you have to have some idea. Theory and science is based on scientific principles. So obviously 120 minutes is 2 hours, as we talked about since September 24. 100, again, you have got 100 best of single best answer, best of 5, and 1 mark per question. So these are fixed, 1 mark per question. Whereas before there was variable scoring, which means different questions had different marking. So difficult questions had more marks. If you got one cardiology question, you were wrong, you lost a lot of marks. Whereas some other questions, they were marked lesser marks. It's easier questions. Now it is 1 mark per question for your foundation of practice and also for your theory and science. Applied knowledge in practice, AKP or clinical application. Now, this is the one we practicing doctors, young doctors or doctors who are working in hospitals and daily practice, we are more used to this. We will know how to, it's about scenarios where a patient child comes to the hospital in an E&E, suppose a convulsion, or suppose someone has got, urine protein in the urine or blood in the urine. So, how do you take it from there? What are the first investigations you do? How do you manage it? So very much what you're doing, but you should know the UK guidelines, nice guidelines, because obviously if you're familiar with the Indian IAP guidelines, you might struggle a bit. Their nice guidelines are a bit different. So 300 minutes total unchanged, 120 best of 5. So 60 questions in the morning, 60 questions in the afternoon. And again, 1 mark per question. Before it was variable scoring. Okay, so I hope that helps as well. And what are the answering strategies? As you can see, only 100 questions, 72 seconds per question, 120 minutes total. Whereas that is for FOP and TAS, whereas AKP, 120 questions, only 150 seconds per question, 300 minutes total. Now, how do you approach it? So first, answer all the questions you're confident about. So 42 seconds, not more than that for each question. Then you go to the flag system where you mark uncertain questions for review. Second pass, return to flag questions. Those which are difficult, don't waste time. Come back a second time and then go through. And always select an answer, no negative marking, okay? So that's what you do. So I know this is a bit short, small to read, but basically read question stem first, formulate answers mentally, go through 5 options and select the best answer. And always see the last 1 or 2 choices because they are very subtle differences, and that is what makes the differences. Now, I did tell you that I will give you a very detailed guidance about secrets, so to say, how to make the best for this MRCPCH theory exams, which very few people will tell you. And I've done, to be honest, a lot of research on this. And I hope these points do help you because your mindset has to be, aligned to the question, the type of questions, and otherwise just knowledge is difficult. So what do you do for these single best answer questions? How do you deal with them? So obviously compare all 5 options carefully. Look like see the terms like most, best, and least. Don't miss these words because this will determine the right answer. And one correct answer. Choose the best match. Don't just any match. You have to make sure that answer is the best match. And don't do correct sounding option or assume that there are more than one right answer or read too much. Don't overthink. Again, do practice with obviously RCPCH style. So you have to go through questions which are of that standard. Study explanations. You have to know the explanation for why the answer is for that question. And sometimes if you're studying for some time, you should know the themes which keep coming again and again. Now, obviously, don't look for answer sequences for patterns where there are no patterns, or don't get stuck on the exact wording of guidelines. Don't get confused unnecessarily. And definitely do not skip questions because there's no negative marking. Now, content distribution, as you can see, approximately these are the main topics: general pediatrics, neonatology, cardiology. So blue is general pediatrics, and cardiology, you do get questions. You have to be good about it. Neonatology, few number of questions. Neurology, infectious diseases. So these are the topics. We have core specialty categories, as we mentioned about the specific topics which keep coming again and again. Obviously, ethics and law is something you have to study separately. Consent and capacity, child protection, confidentiality, end of life. And this is where Indian candidates sometimes lose marks unless you are well prepared for it. Okay. So now, how do you prepare for these exams? So obviously, study approach should be very specific. So you should have a systematic topic coverage. That does not mean that you go from, chapter 1 of Nelson and then go to chapter 2. No, does not mean that. It means you go through the questions, find the common topics in maybe the chapter of respiratory, find what are the common topics, like cystic fibrosis keeps coming, or, chest infection, pneumonia keeps coming. And then do it properly, study on that, focus on clinical reasoning. Most of the time you're being checked for clinical reasoning. This is not an exam based on your learning skills, or just how much you can just learn, mindless learning. No, it is about your clinical reasoning that they're trying to check you. And prioritize high yield areas. When you go through questions or you're going to go through a course, you will know which are the high yield areas. And that is the reason why you need to do a proper course where you will save a lot of time. Spaced active learning, obviously you can create your own questions. Your concept should be very clear. And sometimes if you teach or discuss with your colleagues, you learn better. Spaced repetition. So obviously these topics have to be got multiple times. And initially you repeat more frequently and then gradually you make the interval more, space it out. And focus, know where your weak points are and focus on those. Now, there is something called mock exams, which we do in our courses. And unless you do that, it's like preparing blindly. How do you know where you are progressing? Week by week, how do you know that? You might be just doing the very common tendency. I used to make this mistake. I used to love certain topics and I used to spend all my time studying them. And those topics which in the exam are important, and which we are not very comfortable with, like pharmacology, something questions like which coming from statistics or some questions like ethics. So you have to know where you're weak, or suppose there are concepts based on blood gas analysis or ventilation settings for this AKP specifically, or cardiac catheterization values, which might be challenging, but you have to concentrate on those which you are not that good, which you find challenging, because in the exam, those marks will matter. So identify where your knowledge gaps are. That is where doing the mock exams in a controlled environment in the courses will help you, and then study accordingly. Now, let's go through a question. I will just going through the time 9:20. So I've decided that probably to give you a taste, especially if some of you are new, to give you a taste of what the exam, questions, what sort of questions will come in the exam. These are very carefully chosen, and I hope you will find these interesting. So if you can, I don't know, you said the chat GP is disabled, but if you can at least answer on the question answer Q&A box, that would be great. So this is a clinical scenario. So 14-year-old girl requests emergency contraception after intercourse. This is a question we went through before. And she has come to the clinic alone. So a lot of medical legal thing. Now the girl appears mature and understands the situation. She explicitly refuses parental involvement. Now this is the question, okay? Now, especially for Indian doctors, you need to know what is the most appropriate action. So one is prescribe levonorgestrel, refer to social services, insist on parental consent, and perform pregnancy test first. All right. So these are the choices. So the correct answer is prescribe levonorgestrel, and why? So this is something we need to know. So the UK guidelines allow confidential contraceptive care for competent adolescents regardless of parental consent. So this is RCPCH ethical guidance. So you need to spend time. Now, there's a lot ethics can be a huge thing in itself, but if you do a proper course or if you do under proper guidance, you will know what exactly to concentrate in the ethics. So there's only so much in ethics which keeps coming for the exam purpose of you. Don't be, odd or be, don't get lost in ethics or start wasting too much time in there, because there are usually certain topics which keep coming again and again, but you have to be very sure about that because it's easy marks you can get. So levonorgestrel is the first and emergency contraception, and this is what you can use. Fraser guideline, now these are very commonly applied in the UK, and as a pediatric doctor you need to have a good idea about it. So they apply for treatment those under 16 years. So obviously as a GP, or sorry, as a pediatrician, you need to be aware of it. So if you find that the young person understands advice, that is what in this question, that's what it said. And they cannot be, so you've asked the child to let us inform the parent, but they have refused. And it is obvious that she wants to begin or continue sexual activity. And you know that without contraception, the child might get pregnant, or there might be some harm to physical or mental health. Then for best interest, you have to give or advise contraceptive advice even without parental consent. So that is the law, and you have to be very clear about this. So what about the other options? So option B was referral to social services, not immediately necessary without safeguarding concerns. So it's not uh, immediate something required. And option C, and now option C was, let's go through the choice again. Insist on parental consent. Now and then again, option D was perform pregnancy test first. So obviously here, against confidentiality principles, there is something called confidentiality principle, as we talked about it. If the teenager can understand things and it is against confidentiality, you cannot do that unless there is dire, risk to the patient's life. Only in that case. Option D. Now again, you pregnancy test, while in good practice, you do not require it before emergency contraception, as it will delay appropriate care. So these are the questions, the example of a typical question we'll get. Now let's go through another one. This is called a sample. Is more of a cardiology sort of question. And let's see what it's got. So not very difficult, but very clear, specific answers. So here again, you've got a 3-day-old neonate who presents with worsening cyanosis, tachypnea, and poor feeding. The cyanosis improves briefly, and the baby cries. On examination, there is a single sort of S2 heart, second heart sound, but there is no murmur. Chest X-ray shows decreased pulmonary vascular markings with a normal size heart. So these are all important. Normal size hearts, not enlarged, and decreased pulmonary vascular. So each one is very specific, and there's a single heart sound. What is the most likely diagnosis? So what are the options we have got? So we've got VSD. I don't want to see the answers, so I'm just covering it up on the side. Tetralogy of Fallot, transposition of great arteries, and PDA. Okay, so just make a note if you got it, and then let us see what the answer is. So as you can see, these are very practical questions. The answer is tetralogy of Fallot. Okay, tetralogy of Fallot. Now, explanation is why is it that this is tetralogy of Fallot? Because cyanosis that improves with crying, or which are called spells, cyanotic spells, are classic for tetralogy of Fallot. Single heart sound, second heart sound is due to pulmonary stenosis, which is a part of tetralogy of Fallot. And decreased pulmonary vasculins on the chest X-ray are due to reduced pulmonary blood flow. A normal heart size is one of the features of tetralogy of Fallot, not enlarged as it was seen in other. So let us now see why we have ruled out the other conditions. So VSD was the A choice. Typically presents with loud pansystolic murmur, causes increased pulmonary blood flow, increased markings on chest X-ray, usually not cyanotic in early pregnancy. So that's totally ruled out. Transposition of great arteries presents with severe cyanosis from birth that does not improve with crying. So no cyanosis here in this case, because severe cyanosis from birth, and does not improve. The difference is does not improve with marking. Heart size is normal, pulmonary vascular. So that's another difference from tetralogy. For the pulmonary vascular markings are increased, not decreased. So that is where it makes a difference, because sinus is present in both tetralogy and TGA. And again, heart size is normal in both, so that again causes a problem. But again, pulmonary vascular markings is increased here, which is the different. PDA presents with, as we know this, continuous machinery murmur, not typically cyanotic, and would show, again, this one would show again increased pulmonary vascular markings. So both TGA and PDA show increased pulmonary vascular markings. Just some points. So this is how you prepare for the exam. When you go through the choices, you try to study about the choices themselves, because probably the next question would come related to the same topic, but in another way. So what are the initial management of tetralogy of Fallot? So obviously, next time in the exam, probably we'd get a question on tetralogy of Fallot and management of tetralogy of Fallot, and it keeps coming all the time. And they try to confuse you between the different, the deadly, what are the challenging congenital heart diseases, the ones we talked about. It comes again and again. The PDA, the tetralogy of Fallot, transposition of great arteries, these keep coming in the exam again and again and again. And they will try to confuse you so much. And in the pressure of time, you have to act very fast. So prostaglandin infusion is, as you know, to maintain ductal patency, is severely cyanotic. Propranolol for hypercyanotic spells, and obviously definite treatment is surgical correction. And there is something called knee chest positions, which use to increase systemic vascular resistance. So these are some of the things which, at least for exam point, you need to be aware about. Now let's talk about the key features of tetralogy of Fallot, as you know, because the whole question is based on that. So pulmonary stenosis, which causes the reduced blood flow and decreased pulmonary markings on X-ray, right ventricular hypertrophy, VSD, and overriding of heart rate. So these are the main things. So this is a question on neonatology. So let's see what the scenario is. So you got a 2-day-old term baby who's weighing 3.4 kilo and presents with jaundice. The baby was born via normal vaginal delivery after an uncomplicated pregnancy. Mother is blood group Rh positive, and the baby is blood group Rh positive as well. The typical serum bilirubin is 210 micromoles. Now here, and obviously for the UK exam, you have to be familiar with their units, because their units are a bit different. Yeah. So what is the next appropriate step in management? Now let us go through reassurance and follow-up, immediate exchange transfusion, and phototherapy. Now, obviously, in this case, unless you know the values, you would have no idea. So an IV immunoglobulin, so that's another thing. So this is the chart. If you look at the chart, this is a chart. So this is the total serum bilirubin in micromoles per liter, and hours after birth. The neonate's bilirubin level 210 micromole at 48 hours. So this is 48 hours, and you're here. And this is the phototherapy. So this is good for phototherapy. And whereas the red one is exchange transfusion. So exchange transfusion at 48 hours, you have to be above 300 micromoles. So as I said, you have to be familiar with the units here. Otherwise, you will struggle. So the answer is obviously phototherapy. It's not anything else. Now, obviously, it's not RH incompatibility, but it is a case of ABO incompatibility. Total bilirubin of 200 micromoles at 40 hours is definitely above threshold for phototherapy, not for exchange transfusion. It is a risk factor for significant hyperbilirubinemia. Now, there are no other complications apart from ABO incompatibility. Why other options are incorrect? Obviously, reassurance is not appropriate here. You have to treat with phototherapy. Exchange transfusion is too, we saw the levels have to be above 300 for that. And immunoglobulin, again, is where do you give IV immunoglobulin? So you have to know that as well, because the next question might be on that. Is indicated for severe hemolytic disease not responding to phototherapy or for approaching exchange transfusion levels. So be aware of that. What is the role of IV immunoglobulin in phototherapy? Now, what are the management pearls? So continue breastfeeding during phototherapy, monitor bilirubin levels every 4 to 6 hours. Obviously, now you have to know exact what bloods to do. You do it all the time, but for the exam purpose, direct bilirubin, blood group, direct Coombs test, and J6PD. So these are the tests they want you to do. And double phototherapy if the levels continue to rise. Now, these are based on NICE guidelines for neonatal jaundice. And so you need to know what the NICE guidelines, at least the summary. The NICE guidelines can be quite big, but you have to know the summary at least of the main points. Now, we have got this thing about I think just for giving a bit of a break, I gave you about what is a focus study approach. And I think we know that, just a repetition of the main points about spaced repetition, topic coverage properly, active learning, and we talked about progress tracking. Basically, what progress tracking means, you have to do mock tests regularly. Now, this also helps with the timeline planning. And this is very important. And I wish someone had told me this before, because we did it by trial and error, like fumbling in the dark. no one really explained to us that this is specifically the most effective way to study. So how do you prepare? So if you have 3 to 4 months before the foundation phase, then this 2 months before is the consolidation phase, and the first month is 1 month is the simulation phase. The foundation is to create a detailed study schedule. Now you go systematically by topic wise. Don't not chapter by necessarily. Even if you go by chapter, go through. Don't have to go through all the topics. If you go through the question papers, as I said, for respiratory, you know what are the topics which keep coming in the exam, and go through that systematically. And you practice questions, go through a lot of questions, but you don't have to time yourself. You can do it in an untimed way. Now, 2 months is before the exam is consolidation phase. So that is where you do focus practice, at least 1 to 2 blocks daily. And you see where your knowledge gaps are. So see where you're making the mistakes and make notes of those topics which are you're so weak at. As I said, you could be weak in statistics, you could be weak in those questions which come with cardiology. I was struggling with that. Or some questions which deal with metabolic medicine. So make sure that you identify them and use make best use of your time, go through that. 1 month before is the simulation phase. This is where time practice, full length test. Remember, this exam is not only about knowledge, it's about how you apply your knowledge correctly in that standard time. In the when you have got the time of pressure of time, you've got only 70 seconds per question. How calmly, how focused you are, how full of concentration you are, how you can perform under pressure. It is a test of that. It's not only knowledge, okay? So we have seen a lot of people who are very calm, who are focused, and they can do much better. So it depends on, and that comes with practice. You have to practice yourself under timing. So like in our courses here in Dr. Academia, we do mock exams with limited, where we do wide variety of questions, but timing is essential. You have to finish in that time. And that's how you know how you are working under pressure, how you can see for yourself how you're progressing week after week. Okay, final week is now refinement phase, because there you're only doing high yield topics. You know that these topics keep coming again and again. And weak areas, as I said, you could be weak areas. Some questions on, I just mentioned cardiac catheterization or blood gas or metabolic medicine or pharmacology, mechanism of action. These are ethical questions, statistics. So you need to go through them really. And this is, I think, one of the most important is maintain regular sleep schedule. So towards the end, I've seen people who have not been able to manage their on-calls, or something comes up. And if you do not sleep well, the problem is you might study too much, but actually the day of the exams, if your mind has not rested properly, if you've not had very good rest, your performance will suffer. Take it from me. Your performance will suffer. Now, high yield areas for 2024, as I said, the cardiology is one of the congenital defects. We went through that, arrhythmias and respiratory asthma, infections and cystic fibrosis very clearly, jaundice, prematurity, RDS, in infectious disease as well. Mainly, very common questions come on exanthem, basically rash with fever. So you get a lot of questions with different types of viral exanthem. So 5-day rash, 6-day rash, chicken pox, measles, mumps, slapstick appearance. These keep coming again and again. Hand, foot, mouth. So the combination of fever with rash, you have to know very well. And you will get sometimes in the AKP question, the pictures as well. So meningitis keeps coming, sepsis keeps coming, ethics and law. I think we know that. You have to study about that. And seizures, development medicine, headache, these do keep coming as well. So the success tips are pattern recognition. It's only when you practice again and again, you will just start seeing what the pattern is. You will see rule out distractors. So some choices are there to distract you from the main choice. So you have to identify that these are just there for diversion. And review explanations. So understand when you're going through rough questions and answers, go through the explanations thoroughly and focus on application over recall. So it's not just about learned knowledge, it's about how you understand the concepts and you apply it to the question or to the question or to the scenario in front. It's more about, unlike Indian questions, more about application to the real life. Okay, that's what it is. So, and also simulate exam pacing. So that we talked about anyway. How are we doing? So about 9:40. So just go through one or two questions more. So now this one, again, I think we went through the answer, but again, I'd like to go through this. A 10-year-old boy is brought to the emergency department with a 3-day history of vomiting, abdominal pain, and excessive thirst. He has lost weight and reports frequent urination over the past month. On examination, he appears dehydrated with Kusamol breathing. It's very obvious. And this topic keeps coming again. That is vital signs show temperature 37.2. Excuse me, heart rate 130 beats per minute, respiratory rate 28 per minute, blood pressure 105/70. Biochemistry results show blood glucose 28, pH 7.15, bicarbonate 9, sodium 132, potassium 5.5, and urine ketones 3 plus. So now again, you have to have a very good idea about the basic, the normal range or reference ranges for something. And that's why I selected this question, so that you realize that this is what is required really. And what is the most appropriate? Now, again, the answers come out, but again, have a look at the choices. See how it can be quite confusing if you're not concentrating well. Isotonic saline, 10 ml per kilo, 5% dextrose, 5 ml per kilo, hypotonic saline, 20 ml per kilo, rapid infusion. And you can see the choices are very close to each other, unless you're really bicarbonate infusion over 1 millimole per kilo per over 20 to 30 minutes. But this you have to know very well. So let us see what the actually happens. DKA management, clinical assessment, confirmed diagnosis. You start IV fluids, then you start infusion, insulin, then you regular monitor. So only then you go to subcutaneous insulin. That is the sequence of events. Now let's go through the actual answer. It's isotonic saline, 10 ml per kilo per hour. But let's understand why. Because the questions will be based on your understanding of what's happening. Okay. So DKA, first of all, how do you confirm that it is DKA? First is blood glucose more than 11 millimole, that is 28 millimole per liter in this case. Venous pH is less than 7.13 or 7.3, that is 7.15 in this case. Bicarbonate is less than 15, or that is 9 millimole in this case. So obviously, you can see the ketone is 3 plus in this case. The patient has moderate or severe DKA with significant dehydration. So first of all is confirming the diagnosis, for which you need to know the values. Then you go to the management. Now, there are some different guidelines, as you can see. And in India also, it is more or less similar, that you do first is restore circulation with isotonic fluid. Only after initial relationship with fluids, that's when you start insulin infusion. Okay, so only after isotonic fluid, then you start infusion, insulin. Then you monitor the electrolytes. And we have got a schedule, the nice guidelines, how often you should do the electrolyte checking. Then avoid rapid dehydration due to cerebral edema risk, because this is one of the main risks in DKA. If a patient dies, it's because of too fast fluids or electrolyte imbalance can cause cerebral edema. So why the other options are incorrect? Now, see how these are explained and why you should understand. So 5% initially contraindicated with the high blood glucose, added later. So there is a situation where you will need 5% dextrose, even in a case of DKA. But that is once you start, the initial fluids have been given, you've corrected the dehydration, then you started the insulin. And even after that, when the sugar starts falling and the blood glucose is less than 14, that's when you do that. Now, why not hypotonic saline? Because it is absolutely contrary. There's no role for that at all, because it increases cerebral edema risk. Option D, rapid insulin. Insulin should be started after initial fluid resuscitation, not before. The rate, as I said, is 0.05 to 0.1. Now, a lot of questions will come on this. What the rate? Bicarbonate, now again, it's very tempting to say, right, bicarbonate if it's acidic, but not routinely indicated in pediatric DKA. Why? It may worsen hypokalemia and cause cerebral acidosis. So, what are the management parameters? This is a very common question, comes also in, I would say, in various forms. Sometimes we get a question in the clinicals as well. Obviously, it's more about management, basic overall management. But for the theory, you have to be very specific answers. Initial fluid, isotonic fluid or saline, 10 to 20 ml per kilo, 1 to 2 hours. Subsequent deficit plus maintenance over 24 to 48 hours. Insulin after fluid resuscitation, only after that. Rate of insulin 0.05 to 0.1 units per kilo per hour. Potassium, when do you add potassium? When potassium is less than 5.5. And very important, only when urine output is established, not before that. Glucose, only when do you add glucose? When glucose is less than 14 millimole per liter. And monitoring hourly vitals, glucose, electrolytes, and fluid. So that's hourly vitals, glucose, electrolytes, fluid tags. So I hope this question gives you a very clear understanding of what exactly goes on there. We've got some time, so I'll go through 1 second. Yeah, 9:44. So we'll go through another question. Now, again, this is a topic which keeps coming in the exam. So I've chosen this. Comes in various ways. So a 2-year-old girl presents to the emergency and department with a 12-hour history of fever, irritability, and vomiting. She appears drowsy and has a non-blanching rash on her trunk and legs. On examination, she has neck stiffness and a positive Carnage sign. Her capillary refill time is 3 seconds. Vital signs show heart rate of 150 beats per minute, respiratory rate 32 beats per minute, and blood pressure is 90 by 60. Lumbar puncture shows cloudy CSF. So this is a typical type of scenario which will come in the exam, and see the question, see how they've asked the question. What is the most appropriate immediate next step in the management? I think by now you know what it is. A 2-year-old child with a 12-hour history of high fever, irritability, vomiting, neck stiffness. I think we know what it is. Now let's see the answer choices. So first their choice is obtain blood cultures and then start oral antibiotics. Immediate IV ceftriaxone after blood cultures. Wait for CSF culture before starting antibiotics. Start IV acyclovir only. Fluid restriction and dexamethasone first. Now you know this is meningitis, yeah? And just a chart to show how do you know, because they have talked about cloudy CSF. So cloudy means bacterial. Clear means viral, or TB, you can get clear or you can get fibrin wet. White cell count they have not mentioned, but it keeps coming in an exam, more than 1,000 to 10,000, whereas in viral it is 10 to 1,000, and TB it is 100 to 500. Predominant cells are polymorph in bacterial. Viral is lymphocytes. TB, so both are lymphocytes apart from bacteria, where is polymorphs, polymorph nucleocytes. Protein is more than 100, so this again is very important. TB is even more, very high. And again, normal, viral, the protein will be normal. Glucose, as you know, is low, less than 40 in both bacterial and TB, whereas in viral, it will be normal. So this is a very important point which keeps coming in the exam. Now, let us see about the answer. So I think it's obvious the answer is IV ceftriaxone and after blood cultures. Now, it seems very obvious, but in the pressure of the moment, believe me, people, you start thinking too much. You start thinking, it seems that, oh, this very so easy question, very easy answer. But believe me, when there is so much pressure in the exam, very often I've seen candidates overthinking the question. They think, oh, it's some sort of trick. And then that's when you start thinking, oh, should I give IV acyclovir? Oh, should I wait for dexamethasone and all sort of things. So be very clear about your, understanding. Explanation. So obviously, why is it bacterial meningitis? And believe in the UK, meningitis, meningococcal meningitis does happen. We've seen it quite a few times, and you have to be. It does keep coming in clinical practice, so that's why it is coming in the questions in the questions as well. The theory: fever, irritability, vomiting, cardiac signs, non-blanching rash is typical for meningococcal. You get this in your AKP as well. The rash, meningococcal rash, cloudy CSF, classic for bacterial, early short tachycardia and prolonged rapillary refill. Now, according to, they are following the two guidelines, the NICE guideline, RCBC guidelines, immediate antibiotics. So you cannot delay antibiotics. You cannot delay. Antibiotics have to give in straight away. You take a simple, when you prick the child, you're getting a cannula in, you get some bloods and straight away give the antibiotic. Now, blood cultures should be taken before antibiotics when possible. So that's what we are doing. Third generation cephalosporins, and we're very clear about ceftriaxone and cefotaxime. They are first line. I have no doubt about it. They are first line. So don't think about here and don't think vancomycin or some other odd medicines or, meropenem and stuff like that. For in the UK situation, ceftriaxone or cefotaxime are the first line. So vancomycin only, so you have to have a reason to add vancomycin, only high prevalence of resistant pneumococci. And when do you start steroids? Dexamethasone is within 12 hours may reduce sequelae, because if it's a meningitis, proven meningitis, got the clinical signs of proving it, then within 12 hours, it may help prevent the meningitis sequelae. Now, why other options are incorrect? So this is very important as well. Oral antibiotics are inadequate for bacterial meningitis. IV antibiotics are required for CNS presentations. We know that. Waiting for CSF culture, well, that dangerous delay. If you're waiting for CSF culture, the antibiotics you have to give immediately because you just don't have time. Acyclovir only, not apparent, not for first line, because you have got clinical, very clear signs of bacterial meningitis with a rash. And option E, fluid restriction. While fluid management is important, antibiotics are the priority. So this is what is very clear. Now we are coming close to 10. So what I'd like to do is, again, before I showing a few things, I just like you to show this graph where it shows the risk of increasing the, if you delay the antibiotics, what in meningitis, how much the mortality risk increases and also the neurological sequelae increases. So this is the risk percentage. And this is the hours you are delaying from giving the antibiotics. So as you can see, the mortality risk and neurological both are increasing in time. So no reason to delay it. Okay. Let's go through one more question, the neurology question. I hope you're finding it useful. Now, so we have gone through, as I saw, we've gone through different topics, right? From, uh, uh, infectious disease. We've gone through case of respiratory disease and cardiology. So these are all the typical questions which keep coming. 6-year-old brought to the emergency department after experiencing a seizure at school. Teacher reports that he suddenly stopped responding, stared blankly, and had subtle lip smackings for approximately 30 seconds. He has no jerking movements of limbs. He has had 2 similar episodes in the past month. His development is normal and neurological examination unremarkable. EEG shows 3 Hers spike and wave discharges. Can I very briefly say that for the UK exams, you don't have to know lots and lots really for even for epilepsy. But there are few patterns of the EEG which you have to know. The most common ones, the 3 Hz spike and wave, the bomber pattern, the other ones as well. There are a few typical patterns, 4 or 5, the main epilepsy types, which you have to know very well because in the AKP they will give the actual EEG recordings, the pictures, and it's very easy to identify, very easy to get marks on that. So what is the most likely diagnosis from the symptom, lip smacking and looking at blankly and all that stuff? And EEG 3 Hz and spike, what is the most likely diagnosis? So I'm trying to make sure you don't see the answers, but anyway. So one is juvenile myoclonic epilepsy, one is childhood absence epilepsy, and benign Rolandic epilepsy and complex febrile seizure. Also temporal lobe epilepsy. So we need to have a very good idea about it. So before we go through that, just be aware of the main types of epilepsy, seizure types. As you can see, focal, generalized. Focal is aware and then impaired awareness. And generalized is motor. And then you have non-motor absences. Absences get typical in absence. Let's see the answers. The answers are obviously childhood absence epilepsy. So you had the staring episode. So why is it this one? Because the child had a brief episodes of impaired consciousness, 5 to 30 seconds, where he was staring. And the age is typical, 4 to 10 years. Blank staring and this lip smacking is, each word is important. It's typical of absence epilepsy. Multiple episodes, short period, high frequency, and no post-ictal confusion. And EEG findings, as I said, 3 Hz spike and wave is typical of childhood absence epilepsy. So why are the others are not important? Why they are wrong? Juvenile myoclonic epilepsy, and believe me, this question keeps coming again and again. Typically presents in adolescence. So whereas this one was 4 to 10 years old, juvenile myoclonic epilepsy comes later on, adolescence and early morning myoclonic jerks. And EEG shows polyspike waves and discharges. So if you go through examination pediatrics, there's a book which we studied, and I suggest you studied very well as well. It's called Examination Pediatrics. And there is a wonderful chart where they've given the main types of epilepsy in summary and the main types of treatment and the main types of the EEG changes which happen for, and believe me, it's hardly 3-4 pages, but that's all you need for this exam. You don't need to study anymore. Benign Rolandic epilepsy features showing facial twitching. So again, just one word, facial twitching, hypersalivation, speech arrest, typically during sleep. So sleep is related to benign Rolandic, morning is juvenile myoclonic epilepsy, and staring episodes are childhood absence epilepsy. Complex febrile, I think we know that. Fever with the age under 5 years, not recurrent without fever. Temporal lobe epilepsy, presents with auras, altered consciousness, and automatisms, but longer durations. Now, management of CAE. So obviously, childhood absence epilepsy, first line of, you do get a questions on the medication as well. So what drug is for what, you need to know. Ethosuximide is for pure absence seizures. And sometimes they will ask you about alternatives, which if they are suppose the child cannot tolerate the first one, valproate. If myoclonic or GTCS, generalized tonic-clonic seizures are present. Lamotrigine can be considered as first-line treatments are ineffective. So you got first-line ethosuximide, alternative valproate, or then you got lamotrigine. So what are the drugs to avoid? Definitely avoid carbamazepine and phenytoin can make it worse. Now the prognosis is good with 60 to 70% revision by adolescents. Now this is a very good chart about the main types of epilepsy syndromes and how to distinguish that. So absence is 4 to 10 years, benign Rolandic, younger 3 to 13 years, juvenile, which was adolescent, more teenagers. Seizure type, brief staring episodes, which is absence. Benign Rolandic is focal, whereas juvenile myoclonic was, myoclonic jerks. I think juvenile was when it was happening at in the morning, first thing in the morning, and benign was during deep sleep. Okay, so that's as well. So benign Rolandic was more at sleep. Now, duration, so as you can see, brief jerks, juvenile myoclonic, even absence is very less, 5 to 30 seconds, whereas benign Rolandic is for quite some time, 1 to 3 minutes. EEG patterns are absolutely important. 3 Hz spike per wave with absence. Benign Rolandic is centrotemporal spikes. Juvenile myoclonic is 4 to 6 Hz spikes, polyspikes. Treatment with absence was ethosuximide. For benign Rolandic, you really don't need it. And juvenile myoclonic was valproate. So these are the main types of treatment. So I hope this was a helpful, summary of the questions. The main types of questions come. Now we've got, I think, another questions here, but I think we are coming to the end of it. So I'd just like to go through. First of all, thanks for your attention. I hope it was useful. Now, with your permission, I'd just like to tell briefly about what we do here, that we have got what we do for the, to help people with the study. So we have something called the Dr. Academia MRCPCH online coaching, and it is designed for busy working professionals. So, it's people who are working already, you got on calls or you're busy in a practice, and we've done all the hard work because I remember I struggled, and I saw so many of my friends struggle because there was no time to go through lots of paper, lots of, hours on the internet and hours of going through stuff to understand, just to understand what you need to read and what you don't need to read. So we have got 3 month intensive programs, 6 months comprehensive programs, and the pacing is for you according to your pacing. It will suit you. And guidance, the faculty, we're teaching more than 10 to 12 years, one-to-one mentorship. And we have got a WhatsApp group where you get answer to all your questions, always there to support you. Now we've got library access, video library, we do regular mock exams, and we got a lot of big question bank with explanations. So we cover all three: foundational practice, theory and science, and applied AKP. And obviously, we've had some good feedback over the years. And WhatsApp communities, obviously, because you need, see, when you're in practicing, if you're a busy doctor, practicing, you're already in mid-career, or even if you're in a hospital doing on-call, it can be a very lonely journey. You don't, and remember, it was a lonely journey for me. So unless you have fellow candidates or fellow people who are doing the same as you, where you can discuss with it and hold you accountable to it, and discuss these questions with you, that's when you automatically pass the exam. So that's why we do the WhatsApp community where people interact, they share resources, clear doubts, and faculty are there as well in the WhatsApp group. We answer your questions and try to inspire you. Video, so we have lots of video available on it's free. You get online access during the duration of the course, and lots of questions, topic wise organized, and it's available on laptop or mobile, and you get access. It's not lifetime access, I think that's wrong, but at least you get during the time of the exams. A regular mock exams is single type questions, performance tracking, and this is a single thing, the mock exam, which we hold and which will make a lot of, you can see how you're improving over a period of time. And we have detailed answers. Deepa has been kindly taking the mock exam most of the time, and Dr. Urmila as well. And you will see how you have detailed answer explanations, which will help you understand, and the target weak area where we focus on that. So obviously, we're doing very well. We've had some good feedback. And as I said, we have got 3 month intensive and 6 months intensive comprehensive classes as well. So we have weekly. So 3 months is someone who have got prior knowledge. So 3 months is for the candidates like who are doing, or who are on DNB or who are doing MD, just pass or just passing now. So they are very much in touch with the basic subjects. They are already gone through Nelson. They already got a very good core theoretical knowledge. So for them, 3 months may be enough. They have weekly masterclass sessions and mock exams and complete access. Now 6 months is more thorough. So this is for people who are, you've been practicing for a few years, it's 2, 3 years, 3, 4 years, you're out of touch. It's like doctors who have got DM or doctors who have busy practices, and they are out of touch with practice with the pharmacology, mechanism of action, or if you ask them about embryology or anatomy, they won't understand. So for you, it's more, 6 months is the right time. And you can do it at your own pace, really. And you have a lot of mock exams, one-to-one mentoring sessions. So that would help, I think, I hope help you. Now, I'll just stop share that. And before I finish, I'll just very quickly share something with you, which I hope will help you and will help you think. One second, I'll just share it with you. Just one or two questions which I want to do, which are what I say is just sort of for your interest, really, uh, is to do with. So I just want to show you because I talked about mind map, and it is my pet, it's my favorite, and I just want to do one or two questions on the mind map thing, just for it's more of an entertainment, really, bit colorful, and I hope you don't mind. We just take one or another 5 minutes, and I just show you how we do this really. Now, so so let's go to the first question, which is cardiology question. So you have a 6-year-old. I hope you can see it. I have shared screen. Yeah, I hope you can see the screen. Yeah. All right. I hope you can see. Now, so can someone can put the thumb up or something, then I know that you can follow me. Otherwise, I don't know where you are. And I hope it's helpful. Okay, so very quickly. So this is a 6-year-old presenting with a pansystolic murmur at the left sternal edge, and there's no sinuses or heart failure. So what is the most likely diagnosis? So VSD. So this is just a question which is not very difficult. So why is VSD? We know because of the pansystolic murmur, left lower sternal edge without sinuses. Now, if it is a smaller, which is big, is different. Now, ESD, why not ESD? Because the systolic murmur at the upper sternal edge with fixed splitting. And this was left lower edge, mind you. Now, tetralogy of Fallot, why not tetralogy? Present sinuses and ejection systolic murmur. And this was the pansystolic murmur. So this is why in the exam, under the pressure of time, it's so easy to get confused. So you have to see whether it's cyanosis, where the murmur is, whether it's systolic or ejection systolic or pansystolic. So many things matter. And tetralogy of Fallot presents cyanosis and ejection systolic. Pulmonary stenosis again causes ejection systolic murmur but upper sternal edge. So this is again an important one. So tetralogy of Fallot and PD, as I said, pulmonary stenosis, both you got at upper sternal edge, and it's ejection systolic murmur. PDA, we all know, is the machinery murmur. So that's the answer for this one. So the answer is VSD. So I hope that was helpful.
So I think the slide is not moving ahead. We can just see the hypoglycemia thing visible.
Are you not seeing this one now? What do you call?
No.
Okay, so just give me a second. Sorry, because this one, because this is a different thing altogether. 1 second. Can you see now?
Yeah, it's visible now.
The pink, it's all in pink. Yeah?
Yeah.
Okay, so should I go through it again? Because you didn't go see that, is it? So there it is. So thanks for pointing out. So this was a cardiology question. We talked about a 6-year-old, pansystolic murmur, left lower sternal, and there was no sinuses, heart failure. What is the most likely diagnosis? And I went through the choices. It was about VSD because obviously it's pansystolic murmur at left lower sternal edge without cyanosis. If it is a small one. ESD, why not ESD? Because it's a systolic murmur and upper sternal edge, and there's a fixed splitting. Tetralogy of Fallot, again, we know it's cyanosis and ejection systolic murmur. Pulmonary stenosis, again, ejection systolic murmur, and it's at the upper sternal edge. PDA will cause machinery murmur. So these are, I would say, comparatively straightforward question, but you have to be very good at it. You have to be identify the question very quickly. Now, another question, again, some of them might seem very straightforward, but believe me, in the exam situation, you get so stressed, you can make mistakes. So respiratory question. 3-year-old with asthma has acute wheeze, and SpO2 94%, respiratory rate 38 with mild subcostal recession. What is the next step? So you've got the few things here: immediate IV magnesium, high flow oxygen, oral prednisolone and salbutamol inhaler, IV aminophylline, and intubation. So, it's a lot of choices there. So what is the correct answer here? The answer is oral prednisolone and salbutamol inhaler. So very straightforward, but you have to be very calm and answer it. So why that? Because this is mild asthma exacerbation, and it's managed with inhaler, salbutamol, and you can give oral steroids. The A, immediate IV magnesium, D, IV aminophylline, and E, they are for life-threatening asthma. And oxygen B, high flow oxygen is only needed if SpO2 is less than 94%. So you need to know very clearly what to give when. I'll go to the last question, infectious diseases. So you got a sorry, I think this one is the last one. I think this one I don't have the answer very well. So anyway, I think we went through 2 questions on the the mind map, just to show you a different way of going through the questions. I hope it was useful. And it being, I think already we crossed 10 o'clock. So thanks for your participation. I'll just stop this 1 second. Stop share. And I'll just stop the recording.